Hello, this is Dr. Michael Lau. This presentation is the one that I gave in the AMWC meeting in 2015. It's a World Congress on Aesthetic Medicine and Surgery. And the title of the talk is Applying Anatomical and Physiological Considerations to Optimize Sexual Function in Cosmetic Vaginal Surgery. So this is a professional technical presentation. I think the information therein could be of interest and helpful for the general audience as well. This discussion intends to answer several questions, such as what factors affect satisfaction and intimacy? How can we use cosmetic vaginal surgery to help improve intimacy? And what are anatomical and physiological factors at play while performing cosmetic vaginal surgery? And finally, how can we apply anatomical and physiological considerations to optimize sexual function in cosmetic vaginal surgery? So this is the exact voiceover of the conference presentation I gave. It took place in Monte Carlo, Monaco in 2015. So this is the presentation. Now, my practice is exclusively in vaginal cosmetic surgery to improve the aesthetic and functions. So looking over a couple years before this talk, I summarized the distribution of my practice. I did 193 cases of labioplasty for minora, and labioplasty for majora 16 cases, and vaginal rejuvenation for 102 cases, and 13 other cases. In considering the key factors that contribute to sexual function, we think about nerve distribution, especially in the clitoral area, and also labia minora. And there are specialized vascular elements in the clitoris, which is trabecular, erectile, and also labia minora is non-trabecular and non-erectile. Still, this engorgement takes place in labia minora during sexual excitation. There's an interplay between both the vascular engorgement and the sensory activation that contribute to optimal sexual function. A paper presented by Dr. Yang in 2005 showed that using the MRI, functional MRI, you can actually see the increase in blood flow in the clitoral urethral area and labia minora area during sexual excitation. If you look at the histology of the labia minora and the clitoris, they're both of a specialized vascular element, but in the labia minora is a dilated vascular space. It's not trabeculated, whereas in clitoris, in the vulva area, they're trabeculated and also they closely pack. So in the case of labia minora, it will engorge, and the clitoris, it will actually have erection function. So Dr. Scobar performed histopathology staining of the labia minora. We show the distribution of the sensory nerve endings. You can tell that much denser nerve distribution in the inner border of the labia minora as compared to the external border of labia minora. So something to keep in mind when we do labioplasty and vaginal surgery. Dr. Scobar further evaluate the sexual sensitivity of the external genitalia using a self-assessment study. The purple area showed the orgasm intensity rating, and the red area showed orgasmic effort rating. In both cases, very similar. The area around the clitoris, the most intense, also around the area, and also the vaginal opening on the vaginal introitus. There are several techniques that can be used for labioplasty. The most common ones are the linear resection and the wedge resection, as shown in this photograph. So people ask which method or technique will preserve the sexual function the best, and I'll give you the answer. Actually, the answer is not which method or technique you use best for labioplasty to preserve the or optimize sexual function. Is how you do the surgery. When you consider the anatomical and physiological factors involving labioplasty and clitoral reduction. We need to think about the nerve distribution. You want to have minimum distribution of clitoral area, especially in the midline, and you also want to avoid thermal damage, excessive tissue handling, and trauma on the internal border of the labia minora, as shown before. Those are areas that are highly concentrated with nerve endings. And also one must consider the specialized vascular elements that is important during a sexual excitation. So you really want to preserve the clitoral bulb structure as much as you can, avoid touching those areas. And also you want to avoid excessive tissue tension during close labioplasty, so that won't disrupt the specialized vascular elements. So those are the considerations you use when you do labioplasty to preserve and optimize sexual function. For colpoperineoplasty or vaginal rejuvenation surgery, the key factors contribute to sexual function would be this. When you think about the nerve distribution as well, which is highly concentrated in the clitoral area, and also the vaginal wall, especially the closer in opening, the introitus, and the specialized vascular element around the clitoral area, which are trabecular and erectile, and then in the vestibule, the introitus, the vaginal mucosa, the non-trabecular, and the non-erectile, and still they engorge and still have increasing sensitivity in those areas. It's the interplay between the vascular engorgement and the nerve distribution affecting the activation of sensation. In mapping out the sensory nerve density distribution of the vaginal wall, a lot more sensory nerve distribution to the mucosa versus the muscle. And you look at the map, the circle on the bottom is the urethra. You can tell the most densely populated area for sensory nerve ending are right below inside of the urethral opening at the second 1/5 partition of the distal anterior wall. The backside is relatively not dense in nerve distribution. So anterior aspects are most important around the area of the urethra and just going in. People call it G-spot. Anatomically can define it, but it's in the same general area of nerve concentration. So for colpoperineoplasty or vaginal rejuvenation surgery, anatomical and physiological consideration would be this. So the practical points are, you want to preserve the nerve distribution and don't disturb the structures that have mostly densely populated by sensory nerve. So avoid the distal anterior vaginal wall, the ergogenic structures. The posterior wall, fortunately, is where all underneath had all of the muscular structure to affect the size of the vagina. That part, you can, still try to preserve as much mucosa as possible, but the damage be a lot less critical. And you should avoid using too much cautery or laser to avoid excessive tissue thermal damage. And you want to, again, preserve as much mucosa as possible because those are the ones that contain the nerve endings, and avoid overtension. Again, specialized vaginal element in those areas, definitely around the clitoris, don't go there, and we preserve the structure, and again, avoid excessive tissue tension won't affect the vascular element. So this is the conclusion of the presentation I gave in Monaco. Please feel free to look through the video library collection that I have, and if any questions or concerns, if I can be of any assistance, we take a complimentary telemedicine consultation worldwide. Take care.